Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
I'm going to do it more gently.
Be a little quiet little mouse.
Welcome back to the Cribsiders.
We're being very quiet today for some reason. Why?
We're being quiet. I got feedback. It's important to always respond to good feedback. I got the feedback that I peaked a little too early in the show. So we're going to start a little soft, and then we're going to build. We're going to build because we got a great show. Isn't that right, guys?
I always peak too early.
Just as our weight should slowly go up as a baby, our volume will slowly climb.
We're going to thrive.
Just like our growth curve.
Oh.
We're thriving at a reasonable rate. Welcome to the show, everyone. I'm Justin Burke, joined tonight by Dr. Chris the Chew Man Chew and our outstanding producer, Dr. Shannon Snellgrove. Say hi, Shannon.
Hello.
We are excited to have you back. Shannon has been one of the original Cribsiders producers. We're so excited to have her back on air as a resident. How's intern year treating you, Shannon?
It's a lot. It's great. It is fun. I'm learning so much every single day, but it's definitely a lot. So it's good to be back, though. It's been a while since I've done one of these, so...
We have missed you and are excited to have you back. And I think this was a great one to come back because we had an outstanding guest, Dr. Adolfo Molina, to discuss failure to thrive, a core pediatric topic. But before we go into the content, hey, Chris.
Yeah?
What do we do on the show?
Oh, we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring you clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine.
We have a fantastic conversation with our guest, Dr. Molina, or more lovingly known as Adolfo, who is an associate professor of pediatrics at UAB, University of Alabama in Birmingham at Children's Hospital, where he is a pediatric hospitalist. He has special interests in teaching QI and social determinants of health, specifically in international adoptees and foster families. In this episode, he teaches us about the 3 buckets of failure to thrive make up our differential, the red flags to keep an eye on, and how this hospital workup may actually be something that an outpatient provider can do.
Now, I just want everyone to stick with the episode because it'll grow on you.
Oh.
Hey!
Yeah.
That's pretty good.
And so, Dr. Adolfo Molina, welcome to the show. Thank you so much for joining us.
Hey, how's it going? Thank you for having me. I'm just honored to be here.
We are excited to have you. We're excited to talk about failure to thrive. We're grateful for your expertise. And before we dive into the content, we always like to introduce our speakers to our audience. And so before we start, can you give us a little bit of a one-liner introduction about yourself?
Sure, yeah. So I'm a pediatric hospitalist at UAB, and I'm a dad of 3, foster and adoptive parent, and kind of an epic QI nerd. That's kind of my world of where I live mostly.
I have so much respect for the foster adoptive parents that come in to clinic. That's an amazing experience. I can't believe that's incredible.
Yeah, it's a lot of fun, and obviously a lot of that credit goes to my amazing wife who does a lot of the groundwork for those things. But yeah, no, it's a lot of fun.
How old are your kids?
They're 5, 3, 5. She just turned 4, and 2. So.
Full house.
Yeah, it's exciting times around here.
Nice.
I guess my first question will be, what's the favorite book right now at bedtime, right, that you guys are doing?
Ooh, at bedtime. Man, they're starting to get into being readers. So there's this, my oldest, he's really starting to get into them. Oh, there's like a whole series of books, and now I'm blanking on it.
The Magic Tree House.
Man, there's some really good
Hungry Caterpillar.
I like Gerald the Giraffe. I don't know if you guys have read Gerald the Giraffe. It's one of my favorite ones, more for when they were younger, but it's so good. It's like one of my favorite ones. That's a classic that I like to use for my kids.
I feel very called out in like primary care clinic for whenever I'm on the peds side, and I go and get a book for a child, and I'm like, and they ask me, is it good? And I'm like, I have no idea. No idea. Looks good.
You'll get there.
We'll go with this one.
I always just tell them it's a really good ending.
Oh.
Try to see if they made it that far.
Monster and the end of the book. That's a good one. That's a good ending. Yeah. The twist.
What about books that you read? Have you any book recommendations for physicians or other learners?
Yeah, I think, it's always kind of like recent memories where you remember. My favorite, most recent book, even as a pediatrician, is Being Mortal by Atul Gawande. I mean, I guess you can't really pick up a book from him and not be impressed and learn a ton. Another one, man, especially if you're going into academics and want to teach, there's a book called The Intelligence Trap. And it's a book about how smart people do really dumb things and how we these biases that we have and how we can get into cycles of just convincing ourselves of things. It's really good. And then When Breath Becomes Air, Switch, all good ones. So
Chris and I have never had that issue with our intelligence getting in the way of getting things that we.
I could gather that from you guys. You guys seem like the kind of 100% right kind of guys. So
totally.
It's the other way.
One of our favorite questions to ask on the show, and one that I am definitely learning every time I hear this on the show, especially being an intern, I love to hear the answer to this question. What is your favorite failure, and what did you learn from it?
Yeah, I was thinking about this question, and I think the reality is that it's not one big epic one. It's probably the everyday reminders that keep me humble. All the multiple times I ordered the thing wrong, and then I think the classic refrain is like, you always know, like, did you really mean to? And it's like it's normally some like awesome pharmacist or nurse on the other side of the line that's helping me not hurt a child. And those are almost daily. I think, they get spaced out for different things, but I think it's just constant. I don't know if there's one big one. It's just all the time. Humility. That's been really good.
Love it.
I love it.
Nice.
Should we just jump into it?
Let's do it. All right. Hey, so Shannon, do you want to introduce our first big case?
Yeah, absolutely. So tonight we're talking about failure to thrive, obviously. So we have a wonderful case for us. Our patient's name is Minnie, and she is an 8-week-old female. She's an ex-39-weeker who presented to clinic at Cashlek Children's for a well child visit, and she's noted to have poor weight gain at clinic. She'd initially been gaining weight well at her 2-week checkup, but subsequently at her 4, 6, and 8-week checkups, she had been noted to not be gaining weight. And now she's 8 weeks old, and now she's even lost weight. Her mom reports that she had trouble latching in the newborn nursery at home. And at home, she switched to formula around 1 week of life. She then started to spit up regularly at home, so was switched to a different formula at 4 weeks of life. And we have some growth chart percentiles for us. Her head circumference is 45th percentile, length is 30th percentile, and her weight is less than 5th percentile. So whenever you kind of hear this, what are you thinking of?
Yeah, so that's always it's interesting because that's a lot of detail, and yet when I think of failure to thrive, there's so much more. Really, it's just so much of it is in the history and getting into every little bit of the detail. But certainly, there's, I think, young child, young infant, really recently out of the neonate phase with trouble growing. And that's, that is the bread and butter of probably the majority of pediatric failure to thrive that we see.
And what do you define as failure to thrive? When does it become worrisome? When is, as a clinician thinking about sending this to the ED, or when is the ED doc even thinking about this is something that really warrants maybe even inpatient care?
Sure, yeah. That question about when to hospitalize or if it's hospitalized is always a little tricky. The reality matters, the majority of failure to thrive care can be done as an outpatient in the ambulatory setting. I'm a little painted, so I think it's probably worth saying up front, I'm a pediatric hospitalist, so I have a different point of view. When patients come to me, I'm at a different point in the severity and time course of their illness. But I mean, we have these conversations all the time with my colleagues out in the community, and the question always ends up being, what is it that we can do during a hospitalization to really help? Trying to get the sense of why they're worried. And I'd say probably some of the biggest reasons would be, honestly, just like pediatricians who've tried and they've been following this kid for a week after week after week. And normally it's really in the young infancy stage where, there's so much vital growth going and people are thinking about neurodevelopmental outcomes and things are falling off the rails. That's where probably the majority of them are that I think of that need to be coming in. And then obviously the more obvious things are, is the kid dehydrated probably? Like, have they been just intractable vomiting and emesis? Those are a little bit easier. Or if normally it's a pediatrician who calls me and they're like, I'm really worried about XYZ specific disease and I need you to help me expedite it. I just can't do it quickly in the outpatient world and it could potentially harm a child.
Can we go back and what are definitions of failure to thrive? Why are we worried about this? When is this something that should be on our radar? What are we talking about when we talk about failure to thrive?
Yeah, so failure to thrive, the fun thing about it is that there's probably not one universally accepted definition on it. I think everyone has different ones and they all have weaknesses and strengths. Again, a hospitalist, so my favorite, and I think it's probably the most valuable, is weight over time. So specifically thinking about general weight for age or weight for length that's crossing 2 percentiles or 2 Z-scores around that time. There's other measurements. There's single point measurements that are really helpful because unlike myself where I get more data, sometimes somebody just shows up with a single data point. So you have to have something to kind of help put them in a frame of reference. But definitely over time, seeing somebody, because life's a bell curve. I guess that's the way I always try to think about it. And everyone is on this bell curve. And it's kind of like that classic, I feel like I think about it a lot because of medical school. When I got into medical school, they gave you that speech. You're like, life's a bell curve. You were used to be over here, but now you're here. And it was a friendly reminder that I wasn't going to be as good as I felt like I was. And the same way for weight, like some kids are going to be the 3rd to 5th percentile and just ride that percentile. And that doesn't cause immediate alarm. So that's why I think over time is such a helpful measurement. That being said, probably the things that are most advocated for by like nutritionist societies, NASPGHAN, would be weight for length measurements. So again, less than 2 years of age, where BMI you wouldn't use as much. And then also there's a lot of mid-arm circumference data from NHANES, but some of that stuff in pediatrics is just a little challenging. There's some issues with the reliability of some of those measurements, which is why I think straight weight for age can be some of the most helpful over time for me.
So when we're talking about age as well, like, is there like an age limit to we stop talking about failure to thrive or not?
Yeah, that the reality is, I think when you talk to a pediatrician's mind, when we say the word failure to thrive, we're thinking about infants, so the less than 1-year-olds. And then we probably tend to use more words like malnourishment for patients who are older. That being said, I actually find an article titled like geriatric failure to thrive. And I was like, oh, I guess some, they use that term outside of pediatric, but in the pediatric realm, for the vast majority, we're thinking about infants really.
So speaking on malnutrition, I was always kind of in the hospital whenever I had one of these patients. I didn't know whether we were just calling it failure to thrive, or is this failure to thrive and malnutrition, or when does it actually become malnutrition?
Yeah, I think that's that. And I think there's a shift here in the way we think and talk about it. So really, failure to thrive is supposed to be a physical sign of malnutrition or undernutrition, while malnutrition, they strive at that. And we're getting a lot of, again, advocacy from the NASPGHAN, Academy of Nutrition Dietetics, the WHO, when you use these words, trying to aim more towards using malnutrition that has more specific diagnostic criteria versus failure to thrive, which also just sounds sad, right? Like it also has like this connotation to it that doesn't feel as good socially. Maybe a little bit of stigma there. So that's why we use it. And then also diagnostically and for coding purposes, just from like a broader scope, failure to thrive is not a diagnostic code. Really, coders are looking for with ICD-10s mild, moderate, or severe malnutrition.
I feel like those are the people that really made the distinction, or the billing coding query people who say, I noticed failure to thrive, but is it really malnutrition?
Yeah.
They're always been in charge, right?
Exactly.
Yeah.
Exactly.
There's probably like ICD-10 failure to thrive due to left toe injury or something small. I know.
So you mentioned the weight for length being one of those really great metrics. And so what else are we looking for on the growth chart? Is there specific things that make you more worried, like if length is also going down? Are there things that we need to take into account when we're looking at the growth chart? When an expert like yourself looks at the growth chart, what are they looking at, or what are some tips to kind of approach that data?
Yeah, it's what's fun is a lot of times when I get medical students on rounds with me on hospital medicine, one of my favorite things, a lot of times they'll have come through the nursery before they see me, and I get to it's just very analogous to the way we think about newborn infants too. So that concept of somebody who is small for gestational age because of their weight, typically their weight, but you can have it for a different parameter, one of the other growth parameters. But for me, it's so helpful to remind them to use that same thought process. Like, is it symmetric or is it asymmetric? And just remembering that our bodies are made such that our body will preferentially feed calories to the brain at all costs. And hence, if something's wrong with head circumference size, that is concerning if it's not being spared for other underlying conditions. That's where I'm more worried about, hey, is this from something that's not just nutritionally based enough in versus some other underlying genetic condition or chronic infectious etiology. So I think there is a lot to that. And then a lot of, in the same way that we think the other analogy would be like for obesity and trying to think about Cushing syndrome and all those things, there's pearls for endocrine conditions. And one of those is also if you have height that is preserved in particular, that makes endocrinologic causes really less likely to have systematic disease from that.
So it sounds like microcephaly bad, and if height's preserved, less likely endocrinology.
Yeah, I think that's the way to remember. Like the way things are going to happen with the child body is weight's going to be first thing to drop off, then height, and then head circumference. And if it doesn't go in that order, that's a red flag.
Do we ever run into problems with the different types of growth charts we have? We have WHO, we have our preemie charts. Like, can you look at one failure to thrive and be like, well, if I use this other chart, they're probably going to be all right. Like, is that an issue?
Yeah, no, you're right. And they're like continuously adding. So I was checking this on our electronic medical record, and we have 27 different growth chart disease types. And that's just what we have on our system. We're not on Epic yet, so I'm sure there's 50 more that are going to be awesome. So yeah, I think it does challenging. Again, it goes back to the challenge of the single point definitions that there are of failure to thrive or malnourishment, because in the end, it doesn't give the picture of time and really what's been going on. I think that's still the biggest issue with it. And then, of course, if there's physical signs and symptoms that are concerning, but really for a lot of our failure to thrive, I'd say it's pretty uncommon for us to see them with a lot of like frank symptoms of distress or, real abdominal distension or other things that really stand out. A lot of times it's just kids not getting weight and or losing weight.
And speaking of these kind of different medical charts or different medical conditions that have their own growth charts, what are some specific ones that are very important for us to use?
Yeah, I think, gosh, and there's so many of them. I think the ones you use the most are the ones you think about the most. So again, that probably just lines up with which conditions are more common for us to think about. So when I was looking through this list of 27, I was like, oh, wow, that's kind of neat. I didn't even know we had those. But the ones that I know for sure most people will know about with a fair amount of comfort will be achondroplasia, because their growth parameters are going to be different. Trisomy 21 and then Turner syndrome are probably some of the most, again, and that just reflects that they're the most common diseases that we see, genetic diseases in the population.
And as far as growth charts go, are there some that are more reliable than others, or how reliable are these growth charts in general when we're using them as a data point?
Yeah, I think it goes back to the fact why I like my favorite concept of defining it is over time, and really not just over time, but also why weight for age is one of my favorite measurements, just as a gross term rather than weight for length, because I think there's lots of studies out there that talk about the inaccuracies of length. So if anyone's actually ever seen a kid measured, they literally, like, the most common way is you lay them out on the bed, right? You lay them out on the bed and you kind of like tick where their head is and you kind of tick where their feet are. And then you try to figure out so that creates a whole group of issues for kids who have like cerebral palsy, arthrogryposis, like how do you actually get body surface area? So there are challenges to the reliability of growth charts that have to be stated, but that's why sometimes weight is a little bit easier, because you can put them on there and just weigh them, recognizing that voiding and stooling patterns from day to day change. But again, over time, even with length, because even if you measure length unreliably over time, there's still probably a trend there that's helpful to some extent.
All right. So as we know, I'm the intern that's here. And I, of course, want to know, what am I going to have to write a note about this kid? So what should be in our differential anytime we have a kid that comes in with failure to thrive? What are kind of the buckets that you want to always think about when it comes to what could be causing this?
Yeah, that's actually one of the things I love about this diagnosis, because it's so when I think about the buckets, it's just so logical and it's easy. I think sometimes you talk to a medical student, you ask them like, what are the causes of failure to thrive? And they kind of like freeze up for a second. But then if you pause and say, hey, if you were trying to lose weight, what are the different ways? What are the different broad ways that happens? What's the different broad ways that anybody loses weight? And then it becomes a little bit, you can step back and be like, oh, okay, well, this is easier. So not enough in, too much out, burning up too much. And as long as you have that kind of big frame of reference, you can get into the details of the differential, but all of it's going to be driven by the history. And then also knowing that the reality of matter is 90+% of the time, it's going to be not enough in. And, Nelson's talks about somewhere around 50 to 60%, but I don't know, I've seen more and more studies, and then anecdotally in my own practice, definitely 90+% of the time, it's not enough in.
And when you say not enough in, can you talk about that exactly as far as what does that mean? What are you asking about on the history? Let's start with not enough in. What are some of the things that cause a kid to not get enough in?
Yeah, so I think it starts with and it's really, I think sometimes we think about it too much, but it really is just, let's get into the nitty gritty and just be like, all right, excuse me, I know you've been talking to a lot of people. Let's just start from the beginning. How do you mix this bottle? Making sure they mix it right. All right, how many ounces do you give them? Okay, and how long does it take them to feed that bottle? And then how many hours later do you feed them another one? And then even though the math should be the same, I always try to ask, okay, so how many bottles in a day do you make them total? And really there's because I mean, to be fair, I'm a parent, again, you're just so exhausted at 8 to 9 weeks and you're just not sleeping. So asking redundant questions over in different ways to try to get to the reality of how much is actually going into this child, and asking it in multiple different ways. So how many ounces do you think you prepare in a day? Oh, okay. So how many bottles or how many things are you going through? Just different ways of asking the same questions. And that is the most important part, the actual feeding history, because so much of it goes to not enough in, that the feeding history is really at the heart of it.
And as part of that feeding history, can you give us a sense of how do you know that what they tell you is the right amount? I think especially as an intern, especially going from medicine to pediatrics, they would tell me, yeah, we're feeding, 2 ounces every 5 hours. And I would have to think, that seems like not enough, but I need to check. And so is there a way that you kind of remember how many ounces is appropriate for a specific age?
Sure. Yeah. And I think when you've done it long enough, you get there is kind of a general sense of okay, the first couple of months, somewhere between 2 to 4 ounces every 3 to 4 hours is generally, depending on the weight, is going to be sufficient. But when they get hospitalized, this is exactly what I do with the residents. We kind of go into the nitty gritty of okay, let's legitimately see how many calories per kilo per day, and then recognizing okay, again, everything in pediatrics is weight-based. So let's look at how much they weigh, and let's see how much they're literally saying they're bringing in, and then remembering our gold standards. And it's interesting. This has even shifted over time, because I remember back in my day when I was an intern, I feel like Nelson's used to break it up by how many calories you needed from 0 to 3 months, and then 3 to 6 months, and 6 to 9, and 9 to 12. And they've become a little bit more liberal about it now. It's 90 to 100 in the first 6 months per kcals per kilo per day, and then the next 6 months somewhere between 80 and 90. So there's a little bit more, you can be a little bit more loose, but generally understanding that they need around 100 calories per kilo per day. And then really recognizing it doesn't matter at each particular feed. This is more when they're in the hospital. And sometimes we get into these kind of strict regimens of how we try to feed them. And really what I tell families, I don't care how you get these blank amount of ounces in them, you figure it out during the day. Generally speaking, probably shouldn't go more than 4 hours, especially in the neonatal phase. More than 4 hours is excessive, but once they get a little bit older, 3 or 4 months, some babies sleep 6 to 8 hours a night, and that's physiologically normal. So you just need to get it in them, in that time frame that you have here.
Now, as you're talking to these parents, they're obviously, I'm sure many of them are, just, upset and horrified that their kids are not doing well. And then they're going to the hospital. And then now you're saying they're not good parents because they're not feeding them well. How do you go about not saying that, not using stigmatizing language, how to counsel the parents and be there for them, and also understand that there are probably a lot of other social determinants that are affecting their nutrition and their feeding. How do you go about that?
Yeah, no, I think I mean, the sole fact that more than 90% of the time is not enough in, and I'll step back to say, like, there are a couple of, you know, some things are just misunderstandings on how you mix a bottle. There's rare times where, someone's breastfeeding and their calorimetrics are off. I mean, that's exceedingly rare and also feels like the worst diagnosis ever to have to tell a parent as well. But I think when they're in the hospital, it's a little bit easier, I think, to some extent, because now it's been stepped up, right? So once they're coming to the hospital, they recognize that something is wrong and people are worried. So I think I get a little bit more grace about asking about a lot of details that seem intrusive and could be a little bit uncomfortable. Um, but I think at some level, you have to, throughout the conversation, it depends. You have to have a little bit of emotional intelligence to look at the family and read them and kind of understanding where they are. And you get a sense when families are worried, like, oh, this is like a thing about custody of my child, and if I'm a good parent. And I think you have to step back and let them know, like, we are here to help you love your child. Like that, our goal is to help your baby to gain weight. And we just want to figure out the best way to do that to help you so that you can do this successfully at home. But yeah, definitely, you know, it's hard. I think there's definitely times where if it's a repeat person, I think there's also a place where sometimes the situations are going to be a little bit emotionally charged where it's almost impossible to have a conversation that where someone's not upset. Because I think there definitely are times, less common, but those situations where it's like, oh, this is the third time, and social services of whatever is getting involved. So being honest, I think those situations sometimes there is no easy way of saying it, and just trying to use definitive terms like, we are worried because your child is not gained weight, showing them a growth curve and being like, this is how it is, and this is what we're worried about. But then, one of the things I'm super excited about, I'm part of a project that's screening for food insecurity for all patients that are hospitalized to our hospital. And not surprising, I guess, after the year we've lived in, to recognize, to just see the truth of the matter. Like, social determinants of health are such a big portion of what happens to these kids, and food insecurity and not being signed up for WIC. And I think, man, there's just something, probably a lot of it is the tone and just recognizing that, like, hey, this is hard. You have a brand newborn baby. A lot of times, like, you have a newborn baby, you're exhausted, and we're telling you you're not feeding them enough. And just be like, I'm so sorry. This is really stressful. What are things that we can do to help you? What are the ways that we can try to, again, reframe it more into, like, how do we work together to make this a better situation and sustainable moving forward?
Now, we do have some medical students who listen to this podcast. Can you explain what WIC is and how this helps in this process?
Sure. So WIC is, federally funded, and that's that process of when you get a little bit older, you think about food stamps and that kind of lineage. But in young infants, it's really that concept of you typically go into a health department and you're actually getting screened by a physician for growth, and they do lead screening and everything, and it has to do with your financial ability. So there's a WIC application, and now I'm blanking. I think it's like if you're 1.5 times or below 150% or below the positive level. I forget the specifics of it, but because that you are funded and given kind of stamps to get powdered formula. That's the most common way to get formula. It's good to remember, there are 3 different ways you can get formula. There's pre-made bottles, which are super duper expensive and nobody does. There's liquid concentrate, which is now, I haven't seen someone use that in forever, but that does matter for mixing to know that it's a 1-to-1. And then there's the general most used is formula that's powder based, but it's expensive. Like a can of that formula can be $30 or $40. So sometimes it's helping families recognize, like helping them through that WIC application to make sure that they can actually get the formula that they need for the baby.
And Adolfo, I know that you have dedicated a lot of your career and some of the research you do in social determinants of health. And as part of the show, we really try to spotlight some of the health inequities that occur with each topic. Are there specific access to care based on race, or is there other disparities that are prominent in failure to thrive that are kind of identified or that you're aware of?
Man, I am not aware of it being published so much. I know there's a lot of the literature is about the etiologies and how to work up. A lot of it, I think, a lot of stuff for hospitalists is like, oh, how to keep them out of a hospital. Like, what do you really need to be hospitalized for? I'm actually not aware of. the literature on health disparities as it relates to food insecurity. But I mean, it makes sense that these are social issues, that something is going on where the care providers, the different people who are caring for this infant, generally speaking, again, are not able to provide the formula. Normally it's formula, not being able to either keep up a schedule or do those things. So they're just so inherently wrapped up in the social support structure of an infant. So
And so for these to kind of round out, these individuals who are coming in where we're concerned about not getting enough in because of either systemic issues against them or their inability, these social determinants of health that you mentioned, once they're in the hospital, once we've done a history on their intake, is there a certain amount that we're expecting them to grow each day to say, I think we've cracked it, guys, I think it's not enough in, that they're growing well now under supervised feeding?
Yeah, man, and that's like a very traditional mindset in the workup and management of failure to thrive. Like, keep the kid in the hospital for a couple weeks, prove that they can gain weight, and that's just for all sorts of reasons. That's rife with like issues. I honestly, I think I have this situation come up a lot with residents who are asking me like, oh, well, how long or how many days do we keep them in the hospital? And the reality is like, if they're proven that they can at least take in the formula and we're not getting reports of like frank vomiting, vital signs are reassuring, whatever workup we have done to date is okay, then there's not a lot of value, because their day-to-day weight just it's so reflective of like their stool and urinary voiding patterns that it's really hard to get a gauge. And sometimes it can be helpful. I think sometimes in the worst situations where it's like the third hospitalization, sometimes those become more of like this admission to keep somebody for a prolonged period of time to really, quote unquote, prove that that they gain weight. But again, it goes back to like it's not fair either, right? Like, it's an artificial environment, like being in the hospital. So can it be helpful? Yes, but I think there's a lot of pushback against that anymore in doing that. So
that's so great to hear, because I thought the answer was 30 grams a day. I'm not going to lie. I thought it was I thought it was going to be 30. Justin, the answer is 30. And this was such a more thoughtful, nuanced answer that is appreciated.
Yeah. That's your Nelson's textbook. Now, I think they go 25 to 30 grams per day on average, 100 kcals per kilo per day in the first 6 months. And those things are true, but a day-to-day measurement, just in general, I don't know that that's really going to capture the heart of like just proving that they've gained weight, and that's what it is.
Yeah, that makes sense. I think we like to control the things that we can, and so that's what we can focus on a daily basis. But no, I think that absolutely makes a lot of sense.
Yeah.
And now if we've kind of figured out that they are able to take in and not, have any profuse vomiting or profuse diarrhea, anything like that, that's making the volume down, but they're still not gaining weight. And we say, okay, this isn't a amount in issue. What do we kind of need to do next? Like, what are the labs that we need to get? What are we broadening our differential to?
Yeah. And so it goes, I think this is failure to thrive or malnutrition as a diagnosis. It's like the quintessential lesson from medical school where 90+% of the diagnosis is in the history and the exam. So again, like there is no, and this is also like there is no standard workup for failure to thrive. There's no like standard, you must get this and that. And I honestly, like one of my favorite articles that I love to share with medical students is this article from 1978. And at my institution, you can't actually access it electronically. So it's literally like a photocopied version, like someone literally used a scanner, and that's how they send it to me. They sent it to me originally. And even then, and this kind of concept has been repeated over and over and over again. And the reality of the matter is like labs are not very helpful typically. So in that one study, they looked at 184 kids with failure to thrive, and they did a slew of labs. And basically what they found was like in the history and physical, 34 of them, which is a big portion, 18% of them, they already were thinking about a diagnosis for these patients. And only of the 2,600 tests that were ordered, only 36 or 1.4% were actually diagnostically helpful. And it was in the patients that they already assumed that something was wrong. So again, and that bears out, I think, in multiple studies that like really it depends on the history. So I think it goes back to like, what are the red flag symptoms? So things that I think about for red flag symptoms, certainly cardiac causes. I think that's like the thing we're all worried about. So like, are they sweating when they feed? And this is honestly, I've only caught one once when I was on an attending only service, and it was really interesting. I talked to this dad, and you just kind of going through like my standard, like asking red flag symptoms, and I was like, does she sweat when she feeds this young baby? And he was like, oh man, she looks like an NBA basketball player coming off the court when she's feeding. So it's like, it's worth remembering, it's not subtle. Like these are things that some parents just, if it's their first time child, maybe they don't recognize it as uniquely different. But sweating with feeds, the length of time it takes, do they have on exam loud murmurs or hepatomegaly? Those would be like these are my red flags for heart causes. And then I kind of probably lump it again into like, then it kind of goes into the not enough in, then I think about like brain things. So then really trying to get a sense of like, does this baby have a normal neurologic exam? Do they have a normal suck and swallow? And going to the history of like, are they vomiting and coughing up a lot of feeds? I'd probably say of all the people we talk to, again, there's no standard workup, but of the people that probably get the most involved in our failure to thrive patients, it's probably speech therapists who are like assessing a lot of the details that sometimes you just don't train about in medical school. Like there are there's a preemie nipple, there's a newborn nipple, there's a size 1, 2, 3, and all these nipples have different flow rates. So they're probably the ones that kind of help us out the most with just the very simple mechanics of how to feed a baby. And a lot of times, I'd say I don't even know, I'm not going to make up a percentage, but a lot of times they are some of the most helpful people right off the bat to kind of help us figure out like if there's a swallowing issue. It's interesting as far as like abdominal I mean, not too much out is like as far as that bucket. I mean, it normally is pretty obvious. It's going to be a very simple story like, oh yeah, they stool 12 times a day and it's like straight up watery. I will say, I guess maybe in the patient population where it's like a first time infant, so maybe they're all yellow, loose, seedy stools. Maybe you hear that maybe in that population, but normally even then they'll have some kind of diaper dermatitis because it's going to be severe enough that there'll be breakdown. And then you start thinking about those malabsorption causes. So really, yeah, man, the money really depends on what you think is going on and kind of trying to focus that workup.
Are there any other labs that might be useful? Like, do we get an albumin on them? Do we do like thyroid studies? Should we do like an infectious disease workup if they have diarrhea? Like, is any of that stuff useful? Like, are there things that we do for no reason?
Yes, there are things. Yes, I think there's definitely things that we do for no reason. I think it starts with the fact that you should start with what you have already. So as a hospitalist too, and maybe I'd speak to the general pediatrician a little different. Like as a hospitalist, there's very few times a baby comes to me and has had nothing done whatsoever. Like that a pediatrician just brought them in. It's rare. Every now and then, like super scared, like this kid looks cachectic and breathing funny or something's wrong. That's a unique situation, but most of the time they have labs. So like, what is your state newborn screen? Like start at the basics. Like what is the newborn screen shown? Most of them have thyroid studies, and again, you can develop hypothyroidism later on. So I'm not discrediting that, but for a lot of the ones in the young neonate, young infant phase, that can be really helpful. I can, again, it goes back to like the utility of them and how diagnostically helpful they are is pretty low. You can argue like a CBC and a CMP are not unreasonable if you get to the point of hospitalization, especially just to be like, okay, well, is this kid dehydrated enough that he's got like secondary renal issues? Does he have acute hepatitis? I mean, pretty uncommon etiologies for failure to thrive, but these are not unreasonable things. Are they anemic? Are they actually, losing blood in the stool? Are they so malnourished that there's actually effects on their their cell counts and everything? So
I think this is great. Just going back to your original comment about do we need to be hospitalizing these kids? A lot of the things, it seems like history taking of feeding patterns, doing the physical exam for a neurological exam and looking for signs of congestive heart failure on history and exam, making sure that there's no other obvious clear respiratory issues or cachexia. But to your point, what are we doing for these kids when we hospitalize them? What's the game plan? What value are we adding when we bring them into the hospital?
Yeah, I think probably the majority of the time. So I think the most straightforward actual benefit, the times where we really are helping is when kids are literally dehydrated and need some IV fluids or an NG tube feed, NG tube, enteral nutrition via an NG tube. Otherwise, it's like expedited workup. Yeah, honestly, like the utility is in a lot of ways very limited. A lot of this can be done I think that's kind of a framework shift in a lot of failure to thrive, the thought process, which is why I think there's some evidence that maybe these hospitalizations, because it ranges, like when people tell you what the percentage, different studies have looked at what percentage of all hospitalizations are due to failure to thrive in a pediatric hospital, and that range is broad, and it probably depends again where people practice medicine and what the practice patterns are. But it can be anywhere as low as, around 1% to 2%, which is still not insignificant, 1 out of every 50 kids you admit, all the way up to 9 to 10%. So I think the utility is to step back, because I guess a lot of it is I'm thinking about my specific institution and what we have and resources that are available. I think it depends on where you are in the country and what's available to you as an outpatient pediatrician. So what can you actually accomplish as an outpatient judiciously versus, hey, like I'm kind of stuck, I'm limited by scope or resources, I'm in a rural place, and ultimately like the easiest way to get this kind of accomplished in an expedited form is to hospitalize the kid. But I think probably some of it is we're just really lucky here that we have multiple pediatricians and pretty good access to care and subspecialists and evaluations that a lot of times there is a little bit of a limited utility in what I can do. I can get there a little bit quicker if people are getting like a little bit more anxious about a young infant. But a lot of the things my community partners do all the time without me ever knowing, and they're excellent at it. How do you tactfully discuss these kind of issues with parents? And man, now in retrospect, right, there's like all these things I really regret ever telling parents before I had kids. And some of it isn't necessarily like content wrong, but delivery wrong and tone, and just being like, man, like, oh man, I'm just so tired. I just totally understand. I'm so sorry. This is really hard. And like, wow, babies are awesome, but they're really like exhausting. Thank God all they do is eat, sleep, and poop, because if not, like, I don't know what we do. But yeah, you're right. There's all these little like things that you don't learn as part of like the just logistics of medical school and even in pediatric residency training.
Yeah, parenting skills, I feel like. It's Shannon, I had a very humbling experience. I think I was a senior resident, so it was like late in training at an urgent care where a kid came in with constipation and was like, yeah, I don't know what's causing it. And the social worker said they were using heaping scoops and like packing the formula, and they were really packing it and using heaping scoops. And I said something like, great, they got more calories. That seems reasonable. And they were like, no, that. So I made it through like 3 years of residency and then learned that from our wonderful social worker.
Don't do that.
And the reverse of that is probably more where you get into the food insecurity and not having benefits to have formulas. That's where the mixing happens. That's where the issue of mixing is most of the time. It's families who are trying to spread it out a little bit more in subtle ways. And those are the ones that potentially come in with failure to thrive and symptomatic hyponatremia. So those would be some of the ones that make us, of the failure to thrive causes. The mixing can be some of the ones that can actually get young infants in a little bit more trouble as far as needing hospitalization. I guess we didn't even talk about that category as well.
Well, and I think that's a great segue into the next question of what are some of the complications of failure to thrive? Why are we worried about this? What are some things that can happen for kiddos who are failing to thrive, and for the ones who, unfortunately don't have access to a regular primary care doctor for whatever reason, or haven't been going to appointments or the ED or the hospital? What's the natural progression of the disease for failure to thrive?
Man, you certainly can get, there's been some rare cases where, you get bad enough where someone is truly like suffering from, these things that you think about in developing nations, more like kwashiorkor or marasmus. Most of those are from pretty severe neglect, and yeah, those are just hard to see and stomach in a lot of ways. But most kids, like, thankfully in the United States, with appropriate follow-up, and then what's nice is like you have between a pediatrician and WIC, they're getting weighed and assessed at multiple different intervals early on in life, that most of the time you can catch these things and make and help them out. As far as the long-term stuff, I don't think that that's really perfectly clear. And it goes back to the fact that this is both there's a biological framework for it and a social determinants of health framework. And like all of that input can affect the way somebody grows and the neurodevelopment of a child. So it's so multifactorial, it's challenging. I think, there's some evidence that about whether or not rapid weight gain right afterwards, how that affects insulin resistance, and how our bodies start, and some of this is a little bit of hand waving, right? Like, they become that's that whole concept of like, hey, we store more fat in these phases, and that's how our body starts becoming more equipped. And does that have a long-term late effect of obesity? Maybe. And then there's just the fact that some kids are small. Again, like I said, life's a bell curve, right? So someone has to be on percentile number 2. And thankfully, these percentiles are better than they used to be when they used to be based on, I think there was lots of struggles in the very beginning where a lot of this was based upon like a small population of white middle-class children. And now, it's based upon larger databases, and certainly the WHO as well has, a different approach when it comes to different countries and different nations. So much of it, there's like this genetic component as well. But I don't know. Again, I don't know. And then I'm not even going to open the can of worms, but then there's all the like, as you get older in age, it's hard to even start putting into the effects of like social pressures, the stigma of weight and social media. So I think the long-term outcomes are challenging to really just attribute to failure to thrive. From a short-term standpoint, I think it definitely in the acute phase affects development and activity. Like if the baby's not being fed, then as far as metabolic things that babies do, eating is the most metabolically active thing very early on. But then afterwards, you start growing, you start turning and rolling and sitting up, and all these things require calories. So they all have effects on like development over time in the severe phase. But most kids, I said, again, it's hard to know the long-term sequelae.
Well, and one thing as you're talking that I was thinking about is obviously the sequelae, if there's a secondary cause, have consequences. And just to kind of close the loop and kind of close out on some of the differential of the too much burned calories. We talked about if you're an NBA player after feeds, we're worried about heart disease. And so for this, I would presume we would want to get an EKG and an echo. Are there other kind of higher level next steps where things that we would be looking for not just heart disease, what we would do, but if the kid is relatively tachypnic, or what are some of the other less common secondary causes that were suspect of in that 1.6% where there was already a suspected diagnosis? What are some of those items, and what are the next steps in making those diagnoses?
Sure. So I think, again, all going with index of suspicion. So of like useful diagnostic imaging and labs, pyloric stenosis, if there's that history that's very consistent with, young infant, recurrent, everyone, I don't know how helpful the word is when they always talk about the, what kind of vomiting they call it, projectile, right? I think everyone's kid thinks it's everyone's parent thinks that their kid's vomiting is projectile. But I think there's certain things like they're hungry right afterwards. It's somewhere in that 4 to 8 week kind of time frame. So, and maybe they have abnormalities of, true hypochloremic, hypokalemic, metabolic acidosis, those things that we learn. So pyloric ultrasound would be one. The chest, trying to think through like respiratory symptoms, certainly congenital pulmonary airway malformations would fit in that world. Most of them, I feel like a lot of them present after they've already had like a round of some infectious cause like bronchiolitis that had an atypical course. And then you kind of look at them a little bit, and you're like, oh, they're a little bit on the smaller side. It's hard because maybe some of it's also biased and framed by the way they come in. So like, we probably wouldn't say, oh, that kid's a failure to thrive. We'd say, oh, that kid has congenital pulmonary airway malformation. And part of that condition, part of the way that they're going to present is with malnutrition. So some of it is also like, again, sometimes by the time they get to us, there's already been such an index of suspicion from my outpatient colleagues and how they think about it that they're not even called failure to thrive by the time they get here because someone's hit like an underlying diagnosis. Certainly we're super lucky as far as like advances in genetic testing. So, if there are things about the child, there's dysmorphic features, strong family history, there's a potential certainly for that to be helpful to be able to understand what's the right growth curve they should be on, but then also like being able to get plugged them into early intervention and different resources.
That's great. Thank you.
So let's say we do this whole workup. We kind of figure out that there's an underlying medical condition that's leading them to be malnourished. When's kind of our flag of saying, okay, this kid maybe needs a feeding intervention? such as like a G tube or going home with an NG if that's a thing, or all the tubes. When should we refer? When should we think about them?
All the tubes.
All the tubes.
Yeah, all the tubes. So I'd say NG tubes are an interesting one because I think that also NG tubes also depend a lot on social determinants of like, where does this family live? What is their access to care when this NG tube gets out? How are they going to get it back in? Will their general pediatrician feel comfortable with it? Can they do it at a local ER? Some institutions train families to put them back in right afterwards. That's not where I was trained. That's which is here at Children's. Of Alabama, we don't do that here for different reasons. So it just depends on the NG tube is always an interesting question. So I guess part of it, you have to go back to thinking like this happens. I think this actually does happen pretty commonly. And it's not always just for the diagnosis of failure to thrive, but any kid who is not swallowing safely for something anatomical, the straightforward ones are frank aspiration. So it goes back to like, what is the reason why that they're not doing this? Is this something, trying to get a sense of, the hardest part is like prognosticating, like how long is this going to last? And how long do I drag my feet and do an NG tube versus, this is a classic question where like, how, or do we just need to bite the bullet and like tell this family probably a gastrostomy tube? And there's a lot of like therapeutic alliance and discussions with families that you have to work through to kind of think through what's the best for their child and your resources. So the question's a little bit tricky because it just depends so much on what you think is going on and what the future looks like. And that's, man, sometimes it's rarely straightforward. Again, kid frankly aspirating every consistency on a swallow study, those are sometimes a little bit easier because we're like, I don't know why. There's some really interesting, I feel like we get these not uncommonly, and some of these kids show up for different reasons, and they get a swallow study, someone will be like, oh, they got like a pneumonia once and somebody checked it, and that's actually even a pathologic cause. But even like a kid who mildly coughs every now and then, they'll get it and they fail it epically. And you're looking at this kid who's been feeding, and actually some of them have been gaining weight. So it's really, some of those can be really challenging conversations with families. But as far as failure to thrive, I'd say it's less common that we end up without an underlying genetic condition in which you feel like the chances that this child is going to be able to swallow normally or get in, maybe if it's like a condition where they're burning to have a higher metabolic rate. I'm trying to think of a condition that wouldn't have a repair. Congenital heart disease, like those are going to probably get repaired. You'd probably balance that with just increasing caloric density in feeds. And we didn't talk about that, but that's the classic question too for mixing. 20 calories per ounce is the classic, like this is what formula should have in caloric density. And that's one of the it's really important because we think about that as far as like how we augment that moving forward for some kids who just amp up their calories a little bit to get in the right amount, that 100 kcal magic number that we think about in young infants. But in the absence of an underlying genetic condition or like a significant perinatal injury where you think they're not going to be able to swallow, I'd say it's probably uncommon that they go to a G tube. A lot of times, if they can swallow safely, we can figure out a way to get it in them or figure out treat the underlying condition. So it's a tricky question. I don't know if that's a satisfactory answer. So I'm sticking to it though.
I like it.
Is there like a way that we could talk about like when to increase calories? I know that's like all of these are like vague questions, like that there's not a great answer to. So, but is there a time? Is there like a thing? Besides asking nutrition.
Yeah, what your nutritionist tells you. It's kind of like when people are like, what studies you get? Well, like, well, almost everyone gets a speech therapy consult. If the speech therapist says you get a swallow study, that's what we're going to do. But actually, these are time. There are definitely situations. So I think when I get a history of a child so aside from like obvious causes like congenital heart disease where they have like less of a desire to eat or they get tired really frequently, every now and then you'll hear the story of a parent who's like, I promise I do all the things, like I'm trying to feed them. I mean, like I get them naked and put ice on their feet and they still fall asleep and I can't get them to take more than 2 or 3 ounces at a time. That's one of those situations where we'll do it. Or a lot of times if you're like, okay, they're far behind and you're talking about catch-up growth, in those situations, normally we'll bump it up a little bit. There's actually WHO calculators and for estimated energy requirements that can actually do some of this math for you to help you get like a sense of, it's a little bit more commonly in older kids, but a lot of times what we'll do is like, okay, this kid is such and such far behind. To help them catch up, we're going to bump them to 115 kcals per kilo per day. But I'd be lying if I said there's like an exact science to that. There's some generalities there of bumping it up and helping them catch up if they're like completely off the curve. And then also when you ask your nutritionist and they tell you to do it.
That's what I figured. That's what I figured the underlying answer was. Yeah.
It's a good pearl.
Yeah. It's a good pearl. You know, again, we're a team. Thank God for all the providers in the hospital.
Usually the last question I ask before we start wrapping up are there any like cool things on the pipeline in the future, like cool tests or other like new types of nutrition that I don't even know where to go with this, because it's sort of it doesn't really quite fit into our topic as well. But are there any cool things in the future that you see coming down the pipeline in this area?
I mean, I guess and this is, I mean, I get it's a little bit of a stretch, but I guess like the whole realm of genetic testing is probably something down the pipeline that potentially could have some effect on these things and anticipating problems with weight gain much sooner. I think, you know, tests for like, you know, our comparative genomic hybridization, that cost, and whole exome sequencing is now, I was just at a Grand Rounds, they were talking about like it's now hovering around a little bit under $1,000 per test, something that used to cost, you know, $50,000, $60,000, and, you know, was mostly experimental design. So, you know, and the ever growing newborn state screen, which is awesome because we're capturing kids early on. So potentially, I think as far as like Failure to Thrive and a lot of things, that might be, broadly speaking, something. I don't know if there's one particular test otherwise.
Procalcitonin.
Procalcitonin. That's right. Fecal procalcitonin. That's what the next test should be.
There you go. And how about any other take-home points for our listeners from whatever level? What are the big things that you think are important to know in caring for a patient with suspected failure to thrive?
Yeah, and I think if hopefully you've gathered it by now by multiple iterations too, but again, it is such, in some ways it's so simple because it's 3 buckets, but in some ways it's really complicated because those buckets can be really deep in their differentials. But again, it goes back to like, this is the thing they talked about in medicine, like the history and the physical are everything in failure to thrive admissions. Like there is no shotgun approach to help you diagnose this, to help you like diagnose an underlying cause.
Great.
Excellent. Nope. Anything you want to plug before we say goodbye to our audience?
The University of Florida, go Gators. How about them? Right? Here we go.
Wow. Are you from Florida? Are you a Florida native? Are you
Oh yeah. No,
I'm Florida man. Nice.
Yeah, I'm from Miami. I joke around like one of those people who like never, like a Cuban from Miami, like never in my 10-year life plan did I think I was going to live in Alabama.
There you go.
And 10 years later, here we are. I love it. So.
All right, go Gators. All right, Adolfo, thank you so much for joining us. This was wonderful, and I feel like has a very simple algorithm approach to a otherwise complicated presentation, and I think this is great, regardless of level, of a great way to approach a very common presentation in clinic, in the ED, and at inpatient. So thank you again for sharing your time, your expertise. We really, really appreciate you joining the Cribsiders.
Awesome. I appreciate you guys. Thank you guys so much.
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website, www.thecribsiders.com.
We are committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcast, or contact us at thecribsiders@gmail.com. A special thanks to our producer for this episode, Dr. Shannon Snellgrove, our showrunner, Dr. Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook. Thank you for joining. I've been Justin Lee Burke.
I've been Shannon Snellgrove.
And this has been Chris the Chu-Man-Chu. Thank you, and good night, and good morning, and noontime, and lunchtime, and second breakfasts, and all these other things. Make sure you eat so you grow. Have a good one.
If we learned anything, we learned that.
Hey, you've already listened to the entire episode. Now claim CME credit. Continuing education credit is provided by VCU Healthcare Continuing Education. VCU is accredited to provide continuing education to the entire healthcare team. Check it out at cribsiders.vcuhealth.org for more information and to claim your credit after listening to this episode.